It's 8 o'clock, and welcome to yet another episode of Marvelous Medicine. The idea was to have a brief surgeons about intensive care, but as usual, Pata wanted to make it sound exciting. So no offense to any of the surgeons in the group. You are very much a team member in the ICU. Dileep is the co-founder of Cloud Physician, which provides 24/7 support to several ICUs across the country using technology. In the end, if we have time, we will ask Dileep to tell us a bit about what exactly he's doing. He did his MBBS from Government Medical College Trichy and his residency in internal medicine from Texas Tech University. Trained in pulmonary, critical care medicine, and sleep medicine at the Cleveland Clinic Foundation. After working there for some time, he moved back to India. His special interests are mechanical ventilation nomenclature, ARDS, neuromuscular respiratory diseases, interstitial lung disease, thoracic and procedural ultrasound, and heart-lung interactions in sleep. I met Dileep because of the Facebook group, The Anesthetists. We had an in-person conference, and at that time, Dileep was part of the faculty. Despite being a busy intensivist, he takes time to answer all the queries that are raised in the anesthetist group in the Facebook, and his concepts are very clear, and he's able to explain even complicated things, and that's why I thought he'll be the right person to do this session. To moderate the session, we have a surgeon, Dr. Biju Pottikat. He's the professor of GI surgery, and he heads the liver transplant team at JIPMA. He did his MBBS from Medical College Calicut and MS from Medical College Kottayam. So Dileep, you and Biju have the Kerala connection. Subsequently, Biju moved to Lucknow and did his MCH surgical gastroenterology and fellowship in hepatobiliary pancreatic surgery from Sanjay Gandhi Institute. He is associated with Kurume University, Japan, Asian Center for Liver Transplantation, Singapore, and Washington University at St. Louis. I'm sure all the young surgeons and those who are involved in looking after critically ill patients will greatly benefit from Dileep's talk. Over to you, Dileep.
Thank you, everyone, and thank you, Doctor, quite a bit for that gracious introduction. The topic that I was going to talk about is how a surgeon is a valuable partner in the ICU, and basically a few things that as an intensivist we would really like the surgical team to know so that we can build a multidisciplinary approach to handling patient care. Of course, various catchy titles have been posted, and looking at maybe other specialists as potential intruders, and sometimes that can be taken in jest, in the sense that when you have a certain plan in place for a particular patient in the ICU, oftentimes there are various specialists involved: nephrologists, cardiologists, GI, surgery, and you need a captain of the ship sometimes in a closed ICU model. That captain is often the intensivist. But in India we have various models: open, semi-open, semi-closed, and I'm just trying to sort of indicate where we stand in the intensive care space by highlighting few common issues that we routinely deal in the ICU and how we approach them from an intensive care perspective. So the agenda is fairly straightforward. We're going to try and present few myths and facts, understand that they are sometimes considered controversial, but the reason why I picked them is maybe if they were controversial 10 or 15 years ago, the evidence base has evolved to such a degree that most of these have been put to rest, and there's fair degree of agreement between specialists that this is probably the right thing to do for the patient. So one of the things that, before wasting time, I just get to the point. One of the common drugs that's used in a modern ICU is furosemide or Lasix. And various things are talked about in the ICU realm, where you say that, it flushes the kidneys, it can protect the kidneys. When you dose it, you give 40. If it doesn't work, you give another 40 milligrams. And it helps with renal perfusion. Some surgeons and some intensivists even today like to combine albumin and Lasix and say that it's very useful in edema. Works well with renal dose dopamine. This is a favorite of cardiology teams. They use it even to this day. And there's always this discussion about furosemide being infusion being better than the bolus. Unfortunately, every single one of these lines is actually has very good evidence that refutes these claims. And we need to move on as how the evidence has matured. And one of the slides that I value when I think about diuretic, furosemide and loop diuretics in particular, is that the patient needs to be in this gray zone of therapeutic efficacy for Lasix to work. And when your creatinine is elevated or your GFR falls, this whole gray box actually moves upwards. And when it moves upwards, you need a higher and higher dose of the loop diuretic to achieve the same impact. So if you think that 20 milligrams was useful for a patient with a creatinine of 0.8, if your postoperative patient has a creatinine of 2.2, you need to give a much higher dose to make sure that this Lasix falls in the therapeutic window. And for another reason, oral torsemide to a patient who's in the ICU, who you want to diurese, is probably not the best idea, because it's going to have a useless therapeutic level. It's not going to come into the range. And it's also going to be affected by gut edema. The absorption is going to be lower. So the idea in the ICU is hit fast and hit hard for most of the things, because you don't have time to wait and watch like many would want when they're used to internal medicine in the wards. The ICU is very different. So if you've decided to get fluid out of the patient, use the hammer. There's no point, dancing around with 10 milligrams and 20 milligrams of furosemide for this reason. And the real facts of Lasix are that you need to dose it above the threshold. So if 40 did not work, do not give another dose of 40 milligrams. Give 80 or 100. In fact, there's a name for that. And the name for that is furosemide challenge test, or an FST. If you're not going to get a response with a 100 milligram bolus of furosemide, it's extremely unlikely that you'll get a response with an infusion. Why? Because we discussed that in this. Because if 100 is causing it to go over the gray bar, an infusion with a much lower dose is unlikely to cause diuresis if 100 did not work. So think about that a little bit. And if you do want to break some degree of diuretic resistance, you want to act along the entire pathway of sodium delivery, which is called sequential sodium reabsorption blockade. So you add another agent, you add metronidazole or chlorothiazide or any other agent that works in the same loop to act as a adjunct. And generally, this combination does change oliguric. There is evidence to the contrary, because sometimes when you give a diuretic, the overall preload falls, and that can reduce the renal blood flow and actually drop the GFR after 6 to 8 hours of the half-life of Lasix is up. So remember, Lasix or any diuretic is not going to flush the kidneys or protect the kidneys. When you have low urine output due to a pre-renal problem like intraoperative hypotension, what you need to do is maintain a MAP of 65 or above, or around 70 with the pressor, give adequate fluid so that you have preload, and sit tight and wait. Sometimes masterly inactivity is hard to do, but that is what you need to do here. Yes, if you have volume overload, go ahead, give Lasix, but the furosemide is not going to help suddenly save the kidneys. That is a huge misconception across the board amongst multiple specialties, not the surgeons. The other thing is that renal dose dopamine can increase the urine output, but it does not increase and improve outcomes from a renal failure standpoint, and essentially has a lot more side effects like arrhythmias, postoperative atrial fibrillation is much more common with dopamine. So largely in a modern ICU, a renal dose dopamine is abandoned. The other favorite that we were talking about is albumin, and I can go through a list of trials, Albios, SAFE study, and there are multiple studies that show that albumin has been shown not to really work in most situations in the ICU. And it's frankly unnecessary in most of these models. And in some cases, such as in TBI patients, albumin has actually shown a harm signal in some of these studies. And the problem here is that what was attractive in physiology in 1970s and 90s, in 1980s in Ganong, where you read that albumin is going to suck the fluid out from the interstitium, and then Lasix, which is albumin bound, works much better. Sounds great in theory. But the fact of the matter is that albumin given IV has a half-life about 6 hours. They've tagged it. They've tagged the albumin with radiolabeled isotopes. and found that it does not stay in the bloodstream for longer than 6 to 8 hours. And where does it go? It gets metabolized because these patients are in a catabolic state. So albumin is not hanging out there as an osmotic agent, but it also seeps through what is called the glycocalyx model. Um, in an inflamed person with SIRS, with inflammatory syndrome, this glycocalyx model, the blue layer, is actually disrupted. And the albumin can move from the bloodstream through that disrupted glycocalyx model into the interstitium. So in fact, albumin can actually retard the absorption of edema in some cases because of this glycocalyx model that has been recently elucidated, in fact, in anesthesia literature as well, which tells us that if you have peripheral edema due to a disrupted endothelium and a destroyed glycocalyx, which often happens in inflammatory states, albumin is extremely unlikely to be useful. Now, to be fair, with albumin levels less than 1.5, no good studies have been done. In fact, the average patients that were there in Albios and SAFE study were having an albumin above that range, 2.1, 2.2, something like that. So if the albumin is 0.8 and you want to try and do something by giving an albumin infusion, I'm not going to cite a study to you because there's no study that includes patients in that group. But truth be told, it's not just about Starling's forces, but the modified Starling hypothesis that takes into consideration this glycocalyx model. So the best data for albumin is in cirrhotics, and that's evidence-based. Multiple RCTs indicate that it actually benefits outcomes in cirrhotic patients, because one of the theories is that frequently cirrhotics who are not infected, who do not have SIRS, who are coming, say, with the hepatorenal syndrome or HRS, have an intact glycocalyx. They have cold shock, not a warm inflammatory shock. So if your glycocalyx is intact and your vasculature is not inflamed, perhaps albumin has a role. The other interesting thing that we talk about in the ICU very often is lactic acid. And the prevailing theories are that it's generated due to anaerobic metabolism, results from poor perfusion, and its measurement can improve outcomes. And the fact that maybe giving Ringer's lactate can worsen lactic acidosis, and that if you have a failing liver, your lactic acid levels are elevated because of liver disease. Again, these things are taught repeatedly in MBBS and MD curriculums, and I have friends and folks who swear by these. Every single line is actually false. So one of the messages that I want to convey to everyone here, and not just surgeons, if any of you are interested in surgical critical care, is to revisit lactic acid hypotheses. They've been looked at in fair bit of detail in the last 15 years or so, and there is significant truth behind it. And one of the things that we need to understand is that we measure lactic acid levels. We do not measure pyruvate levels. And in sepsis and inflamed patients, lactate and pyruvate are simultaneously elevated. And they're elevated because increased glycolysis is occurring because of a higher adrenergic tone. So catecholamines increase the level of pyruvate and lactate. And it is due to that enhanced glycolysis that you actually see elevated lactate and pyruvate levels. We don't measure pyruvate, but we just measure lactate, and we're seeing a surrogate marker of increased catecholamines that the body is producing in response to a sepsis insult. There's also a decreased clearance from the kidneys, not just the liver. It's actually because of a drop in renal perfusion that lactate clearance drops. Now, fascinatingly, when you have cirrhotic patients walking around the streets after they've been discharged from the hospital, they don't have hyperlactatemia. In fact, when you look at liver transplant patients as an outpatient, they have normal lactate levels between 2 and 2.5. If the liver disease alone was the factor to increase lactic acid levels, you should see elevated lactic levels in all patients with significant liver disease. The reality is that the liver is extremely efficient at clearing lactate. It's one of the most common processes in hepatocytes, and even 1 or 2 functional lobes of the liver can actually clear lactic acid. You have to have like a 98% reduction in your hepatocyte count to, in fact, see lactatemia from just liver disease. So the message here is that if you have a cirrhotic patient post-op, or you're doing something surgically with the patient and they have an elevated lactate, don't attribute it to liver disease. Think of all the usual causes of hyperlactatemia, and if you've cleared that out, then go to liver disease. So lactate is not just an acid, it is actually a buffer, and 1-to-1 ratio, it is converted to bicarb by the liver. So when you give Ringer's lactate and you have a functional liver, you are actually giving bicarbonate. That is something that you can think about conceptually. I don't think it's 1-to-1. I think I made a mistake there. 1-to-1 is for acetate, but generally all the lactate is converted to bicarb. So in the ICU space, lactic acid is just a marker of badness. It's extremely non-specific. It just tells you something is wrong. It doesn't tell you if the liver is responsible or the kidney is responsible. These are the theories in the background. And when you give fluids, when you fix their preload, you reduce their catecholamine surge, and lactic acid clearance usually happens. So it is a surrogate marker. We have a study by Jones et al. In JAMA, for instance, that shows that if you've cleared your lactic acid levels by about 20% within 6 hours or 3 to 6 hours, that's a marker for a better outcome. It's not because lactate is the villain. It's just a surrogate marker of overall improvement in the metabolism of the body. And in some cases, it may actually be protective because it is a cellular fuel for myocytes and brain cells. The other thing is frequent in ICUs in India and even in the West is the absolute epidemic use of proton pump inhibitors. This is something that we should actively start discouraging, because there is a harm signal with overuse of PPIs. You can get pneumonias. There is a signal with increased C. difficile infections. And this is something that started in 1994, actually. There was a researcher called Deborah Cook, who first came out with the theory of stress ulcer prophylaxis. And at that point, the evidence was robust because we did not have a good idea about how to support the mucosa in the stomach. Theories upon maintaining a mean arterial pressure were not robust. Early feeding was not the norm. So the risk of GI bleed was much higher, and we needed a PPI or an H2 blocker to reduce that risk. That said, with modern ICU care, with a focus on early nutrition, with a focus on resuscitation and maintaining a healthy mean arterial pressure, the risk of ulcers and GI bleeds has gone down. So if you're in a good ICU and these resuscitation concepts are pretty good, you need more than 1 or 2 risk factors to increase the risk of a GI bleed. So there have been now recent studies published in the NEJM, for example, the one that's quoted at the bottom of the slide, that shows that PPIs in a modern ICU does not result in a lower risk of stress ulcer, because the general overall care has improved. So earlier, it used to be like, even if you have one risk factor, like an intubated patient, you want to use a PPI. These days, we are walking away from that. If you have 2 or 3 or more risk factors, then we are going to be more vigilant towards using a PPI, because there is a harm signal. And clearly, you don't want polypharmacy in the ICU. So we should just be more pragmatic about that. And simply using steroids or NSAIDs alone is not a strong risk factor. And that's borne out by pretty good data, actually. The next one, I know you guys have had already an antibiotic lecture, so I'll keep this brief. There's no role for prophylactic use in simple intubated cases. I'm not talking about surgical prophylaxis, because surgical prophylaxis itself has clear guidelines, and more than 1 day coverage is frankly unnecessary in a simple case. Yes, there are nuances there. The IDSA website clearly delineates which one you could consider a longer course of antibiotics, depending on how clean or unclean the surgery was. But that's the general trend. Trauma cases clearly don't need it as a blanket statement, although there is some controversy there. There is a role for gut decontamination, which may be selective oral or selective for the entire gut. And again, those are early studies. As far as the Indian predicament is concerned with regard to excess antibiotic use and the prevalence of resistance, I think we should be more pragmatic given our situation. So the other interesting thing is we find blanket prescriptions in our ICUs that really give massively broad coverage. For example, cefoperazone, sulbactam, and combining a lot of BLIs, beta-lactamase inhibitors. In most surgical cases, what is being missed is actually gram-positive coverage when you're using cefoperazone. Our recommendation is that you stick with first or second generation beta-lactams, such as cefuroxime, because they have better gram-positive coverage than cefoperazone or ceftriaxone, because third generation does not have good skin coverage, in fact. So if you still want to use cefuroxime with a beta-lactamase inhibitor, that's fine, but at least pick the right cephalosporin. That would be a wise choice in post-operative cases. Double gram-negative coverage is not needed. It's a wasteful practice. So these are some of the examples that I've seen in surgical ICUs, and we've published some of this data in the American Journal of Tropical Medicine and Hygiene as a network analysis of 4 tele ICUs that we were taking care of. So, sulbactam has excellent anaerobic coverage. You do not need to give 2 anti-anaerobic agents for a patient. There are specific indications to do that, and I'll come to it. So combining meropenem or piptaz with metronidazole is just outright irrational. I would suggest that you drop that practice immediately. There's excellent evidence for this. You don't need to do it. Meropenem, tazobactam, sulbactam have terrific anaerobic coverage. You'll be fine. Quinolone use in India is something that's very important, because if you look at data from JIPMER, CMC Vellore, AIMS, Ludhiana, and all our premier institutes, the average amount of community resistance to quinolones is in excess of 70%. So you may simply be wasting time by using a quinolone. Now, if you're in your own area, you have an antibiogram that shows that you have more than less than 20% resistance, fine, consider it. But we have not found that to be the case in our analysis of cultures across our ICUs. So the second problem with quinolones is that it's a second-line TB drug. So you want to reserve it for tuberculous cases and not use it on just routine post-op prophylaxis. Now, Clinda already has anaerobic coverage. Clinda already has gram-negative coverage and anaerobic coverage to a certain extent. It is not a good anaerobic. It's not a good gram-negative drug. It's mostly looking at community-acquired MRSA. So combining Clinda plus metronidazole is a bit irrational, because you again don't need dual anaerobic cover, and in this combination there is no gram-negative cover. So it's pretty much wasteful either way you look at it. So that is something we would discourage again. Doxy plus azithro is another irrational one. Using aminoglycosides alone enhance the risk of resistance bacteria being selected, and we would avoid that. So these are just some common examples. You can refine your practice from a post-operative or even surgical practice over time. When do we add metronidazole? When you definitely suspect amoebiasis, then it has a role. So for example, if you have a liver abscess patient and you want to cover both amoeba and gram-negative agents, piptaz plus metronidazole is rational. Of course, if you're suspecting C. difficile sepsis, then you want to cover all groups, which is gram-negatives, positives, and anaerobes in that spectrum. You would think about it. But outside of that, not a whole lot there to think about. The other thing that I see neglected frequently is DVT thrombosis and its prophylaxis. It is definitely not rare in India, contrary to popular belief. Even in centers that do a lot of oncology work, for example, the HCG network and Ramaya, you are seeing an increased risk of DVTs. So it's basically underdiagnosed. So what I would recommend is work with your anesthesia and your critical care team. As soon as you think the patient is safe, that is about 6 to 12 hours post-op, just give a green light to start heparin. And one of the things that we should think about is maybe having 1 or 2 machines for a DVT foot pump in the ICU, so that even in patients who cannot get heparin, you have some form of prophylaxis available. One caveat, cirrhotics are actually at higher risk of thrombosis. They are not auto-anticoagulated like previously believed. They're actually at increased risk of clots. The other thing close to my line of practice is something about the lungs. Another thing that we see in the ICU is restricting oxygen in COPD patients. So if you have a COPD patient that you're operating for hernia, one of the things that we want to talk about is hypoxia kills. Hyperkalemia simply happens. So when you have a patient who has COPD or lung disease, don't restrict the oxygen. You're not going to suppress the respiratory drive. That is a certified myth. It is just a biochemical phenomenon that is picked up with an ABG, that CO2 rises, and people thought that the rise in CO2 is because of suppression of the respiratory drive. That's not true. So I would caution, even if you're rounding on the patient and you see a COPD patient, you may have heard this in MBBS, we don't do it anymore. Just give the oxygen if it's required. And one of the things that a less experienced intensivist or someone may suggest is that you need to do low tidal volume ventilation in the ICU for everyone. Now, that also is not an accurate statement. If they have ARDS or they're having some form of lung injury, or they have pneumonia, fine, let's do low tidal volume ventilation. But in COPD cases, that might actually slow down your extubation or exit from the ICU, because COPD patients tend to do worse when you drop the tidal volume. They tend to stay longer on the ventilator because they don't have ARDS. They have completely different lung physiology, and you need to tailor the ventilator settings to their lung function. So just a short message there on that. For routine post-op cases, we typically recommend a low level of PEEP, maybe 3 to 5 to maybe 8 if they're obese. And there's no such thing as physiological PEEP. The pressure in my alveoli, when I'm talking to you right now, at the end of expiration is 0. It's atmospheric pressure. If there was physiological PEEP, I would have a positive pressure. And that's never been measured and shown to be the case. It's just a hypothetical construct of thinking. We are giving PEEP in postoperative patients just to prevent atelectasis. There's nothing about this concept of physiological PEEP that is actually true. Routine nebulizations, extremely common in ICUs in India. First off, your budesonide nebulization that you use, Budecort, that is there in intubated patients, highly wasteful practice. 90% of those particles don't even reach the trachea. Forget about the bronchioles. And this deposition pattern has been demonstrated repeatedly in multiple experiments. You're not really helping the patient. If you have bronchospasm, go ahead and use salbutamol, use it in the appropriate dose, and it's helpful. If they don't have reactive airway disease, avoid wasting resources with beta-2 agonists and steroids that are nebulized. Doesn't help. If you have a patient that has bronchospasm, sure, give the beta-2 agonist, but strongly think about IV steroids in an intubated patient, because that is what is going to get the patient off the ventilator. Don't worry about slow healing of the postoperative wound at a dose of less than 40 to 60 milligrams of methylprednisolone. There is not demonstrated to be any retardation in wound healing. So these are wasteful practices that you can right away deploy in your ICUs and save the patient some money, time, and just overall cumbersome care. Fluids, important concept, and I have changed my practice over the last few years or so. And surgeons, more credit to them, over the last couple of decades, they had always pushed balanced solutions and Ringer's lactate over saline. And saline is not normal saline. It's actually a little abnormal in terms of its chloride makeup and overall impact on the pH. We do recommend using low chloride fluids such as Ringer's lactate in postoperative patients. Unless there is symptomatic hyponatremia, don't blatantly use 3% saline. And this is again very common. What we are finding is that the threshold to use 3% saline is really low. And what we would like as intensivists and maybe nephrologists is that you only want to use 3% when you have a really solid indication, which is abnormal neurological function, seizures, something serious. Just because the sodium is 128 and it came down from 132, the first thing you need to do is just fluid restriction. You don't need to give 3% saline. And one of the things that I have found useful in India is, when we were in the US, we would have a 3% infusion and measure sodiums every 2 to 4 hours. It's not really required in India. If you have resource constraints, you could use a bolus-based strategy that is well published and is safe. 50 to 120 ml bolus of 3% will increase your sodium levels by 4 to 6 milliequivalents, and that is satisfactory to correct any acute symptoms. So it's a good strategy to deploy when you're in an ICU and you don't have access to quick labs and you just want to help the patient without the risk of overshooting your sodium targets. So the speed limit these days is about 6 milliequivalents rise in 24 hours. I know when we were in training, it used to be 10 to 12, but what we have found out over the last couple of decades is that that limit of 10 to 12 milliequivalent rise is potentially unsafe, and you want to be even slower than that. You don't want to have a rise of sodium more than around 6 to 8 in a 24-hour period. So that's something that has changed. Remember, when you're fixing sodium, and you give potassium at the same time, it can actually speed up the increase of sodium. So if you have a sodium of 110 and you're giving 3% and the potassium is 2.5 and you're fixing the potassium also at the same time, your rise in sodium will be much faster. So be careful about that replacement. And the second, and the other electrolyte that is sort of the ignored stepchild in the ICU is magnesium. We hardly test it. I would encourage more surgeons to test it more often. But the key to replacing magnesium is not as a quick bolus. You don't want to replace it as a 2-hour or a 4-hour bolus. Prolong it as much as you can, because with functional kidneys, as soon as you see a large magnesium dose, it's almost excreted quickly by the kidneys. And if you want to retain magnesium in the body, which is in the bones are the primary reservoirs of circulating magnesium. You want to give it time so that it all soaks in, to use an unscientific term. And you want to give it over, say, 6 to 8 hours so that your magnesium levels are actually sustainably increased. Very important ion, very often neglected. Now, this is again a good practice change for me over the last 10 years is I have stopped prescribing maintenance IV fluids. Doesn't make sense in a modern ICU. And I'll tell you why. The primary reason for giving fluids is to increase cardiac output. Any other reason that you can come up with can be traced back to cardiac output. In a post-operative patient, if they are euvolemic, you want to give fluids when you are trying to fix their renal perfusion or trying to improve their cardiac output. If you give maintenance IV fluids, it goes at a very slow rate. It doesn't really fix the cardiac output at all because it doesn't change the preload because it's going very slowly. To change the preload and improve output, you need to give a bolus. And these low-level maintenance IV fluids tend to cause fluid overload in most ICUs. And if you do a bolus-based strategy, if you do the math, you end up giving less fluids and meet the preload requirements that the patient requires invariably. So this has been a practice change for most ICUs and it results in better outcomes. So this is something that I would strongly suggest that we can take away, is that if you have a post-operative patient, give them enough resuscitation, give them sufficient fluids, get them euvolemic, and then just have a very simple bolus-based strategy. Follow capillary refill, that's the Andromeda trial. Follow urine output and other surrogate markers to assist you with your bolus-based strategy, rather than just blanket maintenance fluids. And I often see this saline, Ringer's lactate alternate every 2 hours or 3 hours. Makes no sense. Make up your mind, pick a fluid and run with it. And that indecision is indicative of lack of knowledge from the fluid standpoint. So why not just take a well-informed decision that Ringer's lactate is the way to go and run with that fluid choice? Pretty good choice. And the argument that people say is, what about hyperkalemia? Why do we have to use Ringer's lactate in hyperkalemia? Isn't that harmful? And there's excellent evidence to answer this question. And the evidence is that Ringer's lactate does not cause or worsen hyperkalemia. It'll actually drop the potassium because it reduces the acidosis because it's a balanced fluid. And you know that when you correct acidosis, hyperkalemia actually gets better. And the concentration of potassium in Ringer's lactate is 4. There is no way that any fluid with a concentration of 4, when given even in large volumes, can increase the concentration of blood more than 6. It's just mathematically impossible, unless somehow you're concentrating potassium, which doesn't happen, because if your kidneys were working, you would not get hyperkalemic in the first place. So a little bit of a cognitive fallacy there. And if you think about it, saline actually can worsen hyperkalemia. And that's why I put this slide up. So 9 times out of 10, you're going to be correct if you use Ringer's lactate. There are a few places where you would give saline, but I mean, call your friendly nephrologist or intensivist to answer that question. Here's another very common practice, especially in ICUs, that I'm noticing recently, is about using IVABRADINE just to slow down the heart. This is a very risky thing to do. In the ICU, when you have sinus tachycardia, physiology always has a good reason to have sinus tachycardia. The body is asking for an enhanced cardiac output. So if you're going to reduce the cardiac output, you should have a really, really good reason. And IVABRADINE in the ICU has really no defined role. So just because reducing the heart rate makes the monitor look good is probably not the best reason to give IVABRADINE. And unfortunately, I see cardiologists, internists, everyone make this mistake. you may be better off just using metoprolol if you realize why the patient is tachycardic. But the question to answer is why. Is it pain? Is it a lack of volume? Do you need to fix preload? Is it just fever? There could be, post-operative thyrotoxicosis that may be the problem here. And I would use sinus tachycardia as a surrogate marker of something else going on, rather than try and mask it with IVABRADINE. I don't use it in my practice, and I don't find it valuable either. The other thing is, one of the common cause of fever when your professor asked you in residencies, tell me 11 cause of post-operative fever, and you take all your fingers and your toes and count them off, atelectasis is listed as a cause. Unfortunately, research has been done on this, and really it has never been attributed to be a cause. So if you have a patient and radiology is reporting atelectasis, please avoid falling into the trap to attribute fever to the atelectasis. It could be inflammation, it could be a true infection. I wouldn't rest upon atelectasis as a good explanation. So just wanted to throw it out there. Another thing you'll see in your ICUs is that you have an ETT, you have an NG or an OG tube, and then you have another airway like an oral airway, Goedel's airway in place. This is just really uncomfortable. And what that does is that you tend to give more pain medicine, more sedation to the patient, when simply making the oral area more comfortable would go a long way. You can use bite blocks that are comfortable, shown in the slide, that are far more effective at avoiding a tube bite. Just use those. Don't put too many things in the mouth. You cause tongue injury, you cause lacerations in the palate, and just overall discomfort that makes your patient need more sedation, which is the last thing you want to do in intubated patients. Another favorite mode is the SIMV mode in the ICUs. And as we learn more about mechanical ventilation and as we learn more about best practices, we are realizing that SIMV for weaning adds 1 to 1.5 days of extra ventilator time in the ICU. So there are two good strategies. One is a TPS trial and a good protocolized spontaneous breathing trial, which is the recommended evidence-based way to get the patient off the ventilator. We don't even use the word weaning anymore. We go for a liberation strategy, because the idea is that this is not a slow process. Getting the patient off the ventilator is a liberation. It's a quick process, and that's what you want to do in the ICU. And for COPD patients nowadays, we don't even do spontaneous trials. We try and just directly take them to NIV if their ventilative parameters look okay on the ventilator. And in heart failure patients, we actually gravitate towards using a TPS trial. So don't wean, liberate, and choose the most scientifically appropriate liberation strategy, which I just shared with you. Another worry for surgeons is that when they come back from the OR to the ICU, they're hypotensive, and they'll tell the team, don't give PEEP, I want to avoid hypotension. But PEEP, the worry about PEEP causing hypotension is with regard to the RV. And people think that you reduce the RV output and drop the blood pressure. But the heart has two more chambers. It has the LV and the LA. And in fact, when you look at physiological parameters, you arrive at a conclusion, and we can go into detail if you're interested, but the conclusion from a hemodynamic standpoint is that if you have a failing heart, let's say a patient with heart disease, left ventricular failure, the benefit with PEEP is actually better cardiac output. And the PEEP will drop both the preload and the afterload and allow better function, better cardiac output, which is going to heal the surgical wound better because you're getting better perfusion. So if PEEP is going to improve hemodynamics, that is exactly what you should be doing, and not worry about hypotension, because around PEEP 12 to 15, hypotension hardly ever happens, and it cannot be attributed to PEEP. If you're getting hypotension with PEEP at a PEEP of 10, you need to give more preload. You need to give more fluids to the patient at that point, actually. That is a test that your intensivist can do for you. And that is the right approach, not drop the PEEP, because for good wound healing, you need good cardiac output and good oxygenation. And that is what PEEP can help you. So just a side point there about PEEP. Then the other thing that is a good debate here, and the Indian laws are still struggling to redefine this. But as an intensivist, and if you talk to end-of-life experts across the country, DNR is technically not illegal, DNR does not have a legal position. Two different things. If you don't have a law against something, it does not mean that it is illegal. So what we are saying is that DNR does not have a defined position, and the ISCCM and even the ICMR now has put on a robust framework where you can use terminology such as foregoing life-sustaining treatment or no escalation of care, and just make sure that you document your motive and intent. That is what is going to define this process. And then if you document that and say that the patient is not going to be intubated or not going to be resuscitated, that is defensible in court. Futile care, just because it was demanded, does not need to be given, is what multiple legal authorities and medical legal authorities have stated. And yes, this is a bone of contention. It is an area of controversy, but at least what is there on the slide right now is fairly well accepted. As long as your motive and intent are documented and the entire process is well documented and discussed, doctors have not been penalized for this. Finally, one of the things that's really important to modern medicine practice in the ICU is that it has to be multidisciplinary, because we as intensivists realize that we don't know everything about surgery. What happened in the OR? What are the things that you saw on the table that are relevant to post-operative care? What we need to do in the ICU, and this is personal experience, my seniors, my colleagues, all of us have this, is that because there are so many players in a complex ICU patients, mixed messaging is probably the single most important downside that patient families would complain about. So my request to our surgical colleagues and even other specialties is that when you come into the ICU and evaluate the patient, before you counsel the patient, as whether you're a team leader or a team member, doesn't matter, have a consensus, build a consensus with the ICU team so that the message is unified, because this single point, this lack of unity in the messaging is what creates problems. And if we can stand ground, it's going to help us all. And the other thing is to make sure that the expertise that is available in the ICU, it may be a cardiologist or a nephrologist, it doesn't matter. Once you squeeze that expertise out and reach a unified message, it becomes that much easier, because there's no point in the surgeon giving a detailed discussion on ventilation to the patient's family without exactly making sure that those are the right language and right statements to use, because it can land us in trouble. And that is why I don't complain about, I don't go and comment and tell the family member what was seen in the OR. That is a mistake. What needs to happen is that either I talk to the surgeon or have the surgeon available when we are doing a unified counseling. And it only needs to be done maybe once or twice in the patient stay. And then we just need to check in with each other and then have the counseling session. You don't need a multidisciplinary counseling every time, but you should have a discussion before you talk to the family every time. That is a message that I have learned over time and found it to be very successful in terms of shared decision-making and getting better patient and family buy-in. So all these skills about interaction, time management, and shared decision-making, it's an iterative process. And I would encourage both surgical team members, non-surgical team members, intensivists, and other specialties to sort of come on the same page so that we can help the single most important person in the room, which is the patient. So with that, I'll stop. And I think I was told to have 15 minutes for questions, and I think we have more than that. So thank you.
Over to you, Biju.
Yeah, Dr. Raman, it was a nice, detailed and to the
You
point.
just need to be a little louder, please. Can you get closer to the mic?
Yeah. Can you hear now?
Yeah.
Yes.
Dr. Raman, it was a very detailed and nice and to the point presentation, and we really appreciate it. As you know, we used to have a lot of conflicts with the intensivists, especially in severe acute pancreatitis. This is one area where we fight almost daily, because intensivists are always equipped with published evidence, and surgeons don't have time to read the evidence, and they depend on their personal experience and the things. So I want to ask you a very specific question regarding the lactate. We have a lot of questions actually. Already 8 are there in the chat box. I'm sure that some are on the pipeline. on the lactate side, you told increasing lactate is a generalized surrogate marker for a bad thing. But when it gets improved, can we consider the other way? I mean, improvement in lactase, is it a generalized indicator of a improvement of the patient?
Yes. That was the study I was quoting, Jones et al. JAMA 2011, and there are a couple of other papers. It's like saying that if you give a fluid bolus and the heart rate comes down by 10% from 140 to 100, it may not mean much, but it tells you that some physiological improvement is occurring. And that is exactly what lactate dynamics is indicative of in your patient who has an elevated lactate. So yes, the improvement is a good sign, but we don't scientifically exactly know that what component resulted in the drop in lactate. Is it because of better renal perfusion? Is it because of the reduction in catecholamine surge? Is it simply because of dilution by giving 2 liters of fluid? It's not exactly elucidated. But we do know for a fact that in sepsis, lactate rise is not due to anaerobic metabolism. That has been clearly established in 1996 in multiple studies on oxygen dynamics in sepsis, that it's not due to anaerobic stuff. In other states, like when you're doing exercise and running a marathon, there it is due to anaerobic metabolism, but not in sepsis.
So can we have questions from the audience? After that, we'll take up the questions from the chat box.
Dr. Ilango, would you like to say something?
Nice presentation, Dr. Raman. Am I audible, ma'am?
Yeah.
Loud and clear.
So I hope there are young surgeons here. What would you tell them when they interact with a critical care physician in a surgical ICU? What would be your suggestion? What is your viewpoint?
Yeah, I mean, I'm just a pragmatic realist when it comes to that. And that's why I put a slide about valuing expertise and where we value expertise. And I'm very honest with our surgeons. One of the things that any young surgeon, or for that matter, any specialist talking to a team from another specialty, is to just probe and ask questions and go to the why. And the point should be what is right rather than who is right. So the things that I would encourage surgeons to do is to, like you were saying, sometimes you don't have the time to review literature, and that's all fair. Those are fair statements. And one of the dictums that I go by is that while we cannot be a slave to evidence-based medicine, we also cannot allow experience-based medicine to overrule every decision, because these things change over time. 20 years ago, we would say, do not give beta blockers for heart failure. Today, within a week of diagnosis of heart failure, you need to start beta blockers. So, and critical care is a fairly rapidly changing space. And even during COVID, I think it was a very humbling experience for most intensivists. We've made a lot of wrong decisions. And sorry. So my message to the surgeons would be to simply ask questions like, hey, why are you doing X when I was thinking Y? And then come to a shared decision making that, okay, now I understand your perspective and we can move forward. And really understanding the other side's perspective is a learning experience. I think that has been rewarding to me when I was a trainee and then now in practice.
So I had this difficulty when I was a transplant trainee in Pittsburgh. We used to round with a bunch of very skilled intensivists. So these guys saw things from their perspective. For the surgeon, we had different requirements. And we were always at conflict. So we devised a method that I will go through the patient head to foot, and I will take the ICU physician's inputs and then do the presentation during the rounding. So that worked for me. But I have seen that other surgeons, or especially the younger ones, have difficulty in understanding the critical numbers in ICU that are important in the ICU. What would be the numbers you think are very important for them to remember? Now, I think there are a few things like this. When will you extubate the patient? When will you start weaning? When will you extubate the patient? When have you touched the max dose of NORAD or things like that. Do you have any suggestions?
Yeah, it's tough to exhaustively answer that. As you can imagine, we can't cover each system's numeric points. But you know, that's an interesting question, because you are asking what should the surgeons look at guideposts to just kind of make sure
Right.
that they're
Yeah,
on the
that's
right
right.
track. You know, one of the things is that in critical care training, you try and understand what is immediately going to kill the patient in the next 6 to 12 hours, and then walk backwards from that goal. So once we confirm, once an intensivist confirms that, listen, nothing is going to really kill the patient in the next 6 hours, great, we've crossed that hurdle. And how they cross that is they'll sequentially look at organ failures. So you want to look head to toe and see which organ is failing and how fast it is failing. So what I'm saying right now is basically a English language translation of the SOFA score, sequential organ failure assessment, right? So you would say, okay, how's the GCS? Fine. Is the eye opening okay? The neurosurgeons know that. But in the intensive care realm, you want to go one step forward. You want to actually do a CAM ICU evaluation of delirium, because that is an organ failure that you're going to target. Then you walk down, you look at the cardiorespiratory system, you look at the map, you look at the cardiac output, and it doesn't have to be numbers. I remember I mentioned capillary refill in my talk, because in Indian ICUs, I'm acutely aware that it's not going to be possible to measure cardiac output. And the Andromeda trial and other pragmatic trials tell you that you don't need a number, you just need some form of evidence to tell you that that organ is not going to imminently fail. So that is one. Then you have the SpO2 and ratio of SpO2 to the arterial gas. That's relatively easy to calculate, and you can do that in most ICUs. You look at how the patient is breathing on the ventilator. You don't need to go into advanced respiratory dynamics. You can just look at the patient, see if they're huffing and puffing on the ventilator. That's a red flag for the surgeon. You just ask your intensivist, hey, dude, what's the plan with the lungs? He looks like this patient is running a marathon. Can I get some more insight on the lungs? And then you can go over numbers like P2F ratio and RSBI and track that. Going to the pancreatitis example, what an intensivist would look is not just the bowel sounds, but also the overall gut integrity. You know, is the patient catabolic? Is the patient likely to tolerate oral feeds? Then you look at motility, you know, look at whether the bowels are moving. And again, surgeons are great team members there, because they do that more than intensivists do oftentimes. And then we sort of walk down, look at the kidneys again, like we mentioned. This is sort of a mental list that I have, and most intensive have that. And then we put a number label on it. So for the kidneys, we would not just only look at the creatinine, we would look at both the heart, the map, the overall BUN and creatinine numbers, and then try to come at a shared decision making. So again, I don't know if I can do justice to it by taking each organ and then telling the number statement there, but generally this is what you want to look at. And once you've crossed the 6 to 12-hour threshold, then you have a secondary goal, and the secondary goal is optimization. So once you have confirmed that there's no death going to happen from this organ failure, next step is how do you optimize it so that you get the patient out of the ICU. Then you look at those same numbers, but in a greater bit of detail. So for example, you transition from hypoxia, and then you look at minute ventilation and CO2 and pH. And then you look at electrolytes and not just the creatinine, for example, because now you're not looking at death, you're looking at optimization. So that is how I sort of dichotomize it for surgical patients, because oftentimes their protoplasm is a little bit better than medical ICU patients, because medical ICU patients have, you know, profound cell injury in many organs due to their underlying disease process. And it's often not the case in routine post-op cases. So a little bit of a differential thinking would be useful there.
Thank you. That I think the young surgeons would be benefited a lot from those tips.
Sure.
Dr. Pal, would you like to say something?
Yeah, Vidya, am I audible?
Yes.
Yeah, so actually I'll stay away from this very subject-related topics because I have spent, Vidya will know, we are contemporaries for 28 years in direct contact, direct engagement ICUs, dealing with surgeons only. And I have two takes, quite a few. Firstly, I have not believed that there is something called closed ICU, semi-open or semi-closed. That's one thing. And why, I'll tell you. Whenever I say closed ICU, I close the door. The person on the other side gets a fierce passion to bang it open. And that is exactly we declare a conflict zone by choice. So I never did that wherever I have worked. Second one is the semi-open, semi-closed is perceptional. For example, if presently I look after a 15-bed surgical ICU in which about 15 surgeons participate, and I know 3 or 4 surgeons whose beds function as closed from their angle. It has evolved over a time, and some beds function as closed from my angle because those surgeons function that this is an area, this is their subject, they are going to do the best job for my patient. So essentially what I have come to understand is on a spectrum of about 10 over so many places, if I work with 10 surgeons, there will be 3 surgeons who will be, this is not our subject, let me concentrate on my OPD and surgery. They are going to do their best. Other end, there will be 3 surgeons who will be forever saying, this is my patient, I am the captain. But they forget captain is also a member of the team. So that is where other end. In between the zone where, so this is how I look at. And lastly, as far as respect and, respecting nuances of every other specialty, I myself have learned a huge amount of clinical medicine by cross-pollination with my discussion with neurologists, nephrologists, all the logists. And that is my benefit, because I do believe there are only 4 stages in any learning: ignorance, information, knowledge, and wisdom. The last 2 keep on going on. There is no end to this journey. But the first 2 are always very blurred. When we human tendencies, when we are ignorant, we feel we are informed. So just by citing one article or narrating one article, I can't educate anybody. Neither I can get educated. It may at the most make. This is what I would take on. I would make my comments on. Thank you.
Raymond, would you like to say something? Raymond?
Yeah.
Can
I'm
please turn
sorry.
on your
So,
camera as well?
are you sure? Okay. Yeah, there you are. So I had a busy day. I'm sorry I'm late for your conversation. Listening to Dr. Pal, I'm sure I missed out on a good deal of discussion. So I assume the question or the discussion that's going on is whether there should be this concept of closed ICU, open ICU. Is that it?
No, it was just one of the things. I mean, it was mainly
Okay.
the idea is to let young surgeons know what they can do best in an ICU. That's the agenda for the day.
All right. So, so just adding on to Dr. Pal, I can't agree more. The thing is, we don't call it open closed anymore. It's a concept of what we call it as a high intensive or a low intensive or an elective ICU. A high intensive ICU is what that is directed by an intensivist. And I strongly believe that outcomes are superior if an intensivist directs an ICU. That means to say, in a multidisciplinary model, obviously, okay, there is no such thing as closed ICU at all. And again, like I heard from one of the previous people, I do learn a lot from my neurologist, and I also run a surgical ICU in addition to my MICU. Yes, MICU is a lot more complex. The protoplasm is bad. Yes, there are too many medical challenges. Surgical ICU, I do think there is a role for equal participation of the surgeon. Definitely quoting a paper or something that doesn't help. And there should be a mutual learning, between both of us. And surgeons need to take up a big role in the ICU. Definitely, yes.
Dr. Anjali, would you like to say something? Anjali Dawle?
No, madam. That's excellent. Thank you, madam.
Okay, right. So,
Vidya, can I come in?
yes, please.
Yeah, I mean, this is a quite interesting topic, but Dileep, didn't touch any complicated areas or areas that are going to create trouble. I should say, as a surgeon, first of all, there is hardly any emphasis on learning acute care medicine, any of surgical training, whether it is MS level or even MCH level. I should admit my ignorance that I can't interpret blood gases So if somebody shows me a blood gas paper, I don't know, I show to my associate who will know better. Unfortunately, I've been working in hospital where are best of ICUs, and then this ICU people have really spoiled us, so we don't know anything about ventilation or oxygenation or whatever. Like big team, we come in, we'll just look at the Rylsib aspirate, or we'll twist the abdominal drains, and that's all, mechanical things. You don't know anything else. I mean, I should admit. Now, but then, my ICU chief, Mahendran, is one of the best ICU persons. He keeps smiling all the time, and I don't know what goes in his mind. He's like this. Whenever we want a patient to be shifted to the ICU, there's a lot of reluctance there. And whenever we want to shift a patient out of ICU, there's again a lot of reluctance there. I keep telling the patients, today patient will be shifted, the patient will not be shifted. I don't know who makes the decision, how they make decisions, I really do not know. We get a little frustrated there. Now again, quite often when we do around, some junior person only will be there. Like actually what goes in the junior's mind, we don't know. We always want to talk to the chief, and chief is very, very rarely seen in the ICU. But then, of course, whenever it comes to talking to the patient relatives, he does it. See, the certain tricky areas, like if we see that we have a patient with some respiratory issue, then we'll tell the ICU person, please call the chest physician. They'll give a very sort of odd smile. I don't understand whether they like that suggestion or not. I really do not know. Because I thought, the ICU people themselves are very, very good in dealing all the physiology of respiration. There are so many areas. We want a nephrologist to come in, and they're the exact captaincy is a problem. Surgeons think they are, and we are in control. No, we see a patient who's fairly well today, tomorrow totally bloated up. We get so scared, but the intensivists are quite okay with it. And 2 days later, the whole patient will shrink. We get scared. We are surgeons, and we see any such changes in the patient with, these are all a couple of things which I always notice. And then at many a time, we really do not know what the chief intensivist tells the patient relatives. They keep talking to the patients for a while, and I think they are quite convinced, but what exactly he says, I do not know. But what we say is in a very, you please talk to him, he'll tell you. Although the patients always expect the answers from the surgeon rather than the intensivist. They think intensivist has come to rescue the surgeon. And because surgeon has made some mistake, that's how it goes on. Then there's a huge communication gap. One is, of course, we surgeons don't have time to listen to what the intensivist says, or most of what intensivist says, you don't understand. I don't know how to make these things better, because I don't know how is it elsewhere. If it's neurosurgery, no problem. The neuro people take care. The cardiac surgery, even transplant surgeons have some idea about their ICUs, but general surgeons or surgeons at the best is have very little idea about ICU.
I'd like to just make a quick comment, Panta. This problem.
I want Visru to counter me.
No. This issue about intensivists having come to the rescue, that is actually sorted out in my practice by we tell in advance to most patients who are going to need intensive care that it is part of the plan, and that intensivists are going to be on board for this patient in the post-operative period is already told. Not always, maybe not introduced personally, except in a very high-risk patient with a multidisciplinary meeting or something like that. But once it's been already told that patient is needing critical care and will be looked after by other specialists, I think this issue about you are having done something wrong will not happen. That's my 2 bit.
No, that's very true. I even second that, because now we have lately started this even in our hospital for complex surgeries, especially patients like undergoing 16-hour surgeries, the hypex and all that. The intensivist comes into picture right from the outpatient, because many of these people are malnourished. There needs to be a lot of perioperative, preoperative correction also. So me being a physician and then an intensivist, so I am involved in the loop much ahead. So the patient already knows me, and that definitely makes a big difference. So it's not like some fault has happened, therefore the patient lands up in the ICU. It's not like that. It's more of a seamless process. that again speaks good of the surgeon's open-mindedness. Not everybody do that. There are some people who are happy doing it.
Now, one other thing, Vidya, I want to comment on, because in one of the hospitals I was working for, the intensivists often used to push us for source control. Please operate. When we have a look at the images, we don't think. Actually, I many a times I felt that they're over-image a patient. Say pancreatitis, for instance. The patient is running temperature, and I've seen patients undergoing CT scans every alternate day, which we think is not necessary. And even a collection here, a collection there would not require surgical intervention. But then the intensivists keep on pushing, saying, no, go operate, do something.
Right.
Yeah.
I can comment.
Dileep, please.
Yeah, that's actually a really interesting one, because I think with experience, when you have a team, and let's just take the pancreatitis example. See, there is something to be said about dedicated training, experience, and quality. And that is hard to replace, whether you're a surgeon or an intensivist, it doesn't matter. Because once you open a pancreatitis patient for the wrong reasons, you will regret it for the rest of your life. That I have learned from not just personal experience, but also from our surgical colleagues. So my take on that is, see, source control is important. It's critically important to save a septic patient. And generally in pancreatitis, source control may actually be residing somewhere in the gallbladder or in another location away from the pancreatic area, in fact. So yes, frequent imaging is a problem. I completely agree with you, in fact, and that may be secondary to maybe a worry inside the intensivist mind that are they missing the smoking gun, so to speak. And at least if you are in a place where you have decent support from interventional radiology, that has often been a way for us to sort of go between the lines and figure out where we can ascertain that this is a sterile inflammatory collection and not a true infection. And that puts everyone at ease, just as an example. But not everybody is lucky to have an interventional CT scan assisted drain of that particular area. But I can address the source control point. And the point and message there is that if you have a patient with septic shock on 2 pressors and you are worried you've not done source control, you're probably going to lose the patient. So that, I think, there is no antibiotic created that is stronger than a Bart Parker handle. Let's face it, that is the truth. So if there is a collection and it must be drained, there is no gorilla saline that can match a Bart Parker. So
another point, Dileep. Now we have very high power IED consultants now. Now, is the choice of antibiotics, because we always involve IED in our ICU patients. Is there a conflict of interest between the IED and the intensivist? Who rules the antibiotic protocol?
Yeah, it can happen. It does happen. And, the idea is what is right rather than who is right, because sometimes the IED consultants will have a unique insight onto the drug and its local penetration into the tissue and the milieu of the resistance in that hospital. They should know that because that is their job. So, for instance, I may choose, let's say, ceftriaxone for a community-acquired pneumonia. And the IED specialist may say, we need to change this antibiotic or add azithromycin because the prevalence of streptococcus infection resistant to ceftriaxone is high in this place. Now, I would not know that, but I need to be open-minded enough and need to ask them that, hey, this is what I have learned. Can you tell me why you are recommending a different choice? And that is how we have to arrive at shared decision making. And that's how I have learned my lessons, because sometimes the IED doctor will add clindamycin in addition to vancomycin for a skin and soft tissue infection. And I'll be like, there's already MRSA covered with vanco. Why are you adding clinda? Or why are you adding linezolid? And that's when I learned that there is a specific strain of MRSA called the PVL or Proton leukocidin strain, Vantine leukocidin strain, that the toxin of that strain only is reduced by clindamycin and not by vancomycin. So we wouldn't know these finer details. And that is where their nuance comes in, and I respect that.
Dr. Patta, just a small point I just wanted to add on. See, when an intensivist tells you about to open the abdomen and see, it all depends upon, there are two areas where this is very evident. One is liver transplant and severe acute pancreatitis management. There, if your teammate is a dedicated person, let us say transplant scenario, transplant surgeons are not surgeons 100%. They are a little bit physicians, little bit intensivist, and like that, the people who are managing severe acute pancreatitis, the intensivist will, if he's managing it very regularly, he will obviously know which collection to be drained. I'm reasonably sure about. So
I agree with that.
Team develops, their opinion has to be valued much more. Let us say intensivist is managing lung diseases, kidney diseases, along with that one or two pancreatitis also, probably I want but their opinion. But at the same time, if he's managing a very big ICU with a lot of acute pancreatic cases, he's telling you, please train this. I think that has to be very
Go
much.
for it. Yeah. Another good example is ischemic bowel. So I know young surgeons, when I have a patient with ischemic bowel dying from sepsis, I have them on, 1.5 pressors, their pH is 7.1. I know if it's a short segment ischemia, we know that this is a salvageable patient, at least in the ICU realm. And the surgeon will say that the patient is too unstable for the OR. Yes, that is a known statement. And we as intensivists agree that there is a high risk for this patient. But the point here is that if you immediately start high efficiency dialysis, put them on a higher dose of pressors, get the dead bowel out, this is the only patient that you can save with aggressive care. So it's sort of that shared decision making that becomes important, because when you see a short segment bowel ischemia and you save them because your surgeon was aggressive, your nephrologist was aggressive with early dialysis, making sure that the patient can come out like a rose, action makes a difference. So that is sort of a contrasting scenario where we are on the other side of the table, where the patient is anyway going to die if we don't do anything. It's a matter of trusting the right hands at that point.
It is easy said than done. Dileep.
Yes,
in a corporate sector, I'll tell you, put a knife, patient dies, see operated, patient die. It's very difficult to take the blame.
There's no question about that there are non-medical concerns that will always cloud our judgment. But I'm saying purely from the scientific perspective, this is something that we see. This is not a rare occurrence. The dead bowel after atrial fibrillation is fairly standard. You will see this every now and then in any ICU. So
I would like to say a few things for a few sentences for colleague surgeons here, and I will find out what Dileep has to say about what I'm going to say. So regarding these references, cardiology reference, pulmonology reference, XYZ, various organologists come, scribble there from their tubular, that organ point of view, and then go away, because surgeon gave that reference. And just now Patta mentioned that the intensivists don't like it. And there I stand there here that I'm seeing this patient 360 degree for last 4 days. How on earth another person for 10 minutes can have the same view? Now, under these circumstances, I just want to make a statement. Intensive care is a subject which is like knowing something of everything, not everything of something. And this sentence is very vital to be understood. So really, yes, Dileep is not a nephrologist. Dileep is not a cardiologist, not a pulmonologist, but Dileep knows something of all this. So finally, as a captain of the situation, he is entitled or obliged to collect these opinions, but finally he's not under obligation to implement any one of them blindly. Can I get am I right in this? Because this is what I want to do.
So I have, this is taught to me by a gastroenterologist when I was in my second year of residency, is 2 rules of consulting. And 2 rules are, if you're going to call a consultant, have an exact question why you're calling the consultant. Just because they have a pneumonia, you're not calling a lung doctor. Just because one echo report showed an EF of 35, there's no need to call a cardiologist. You need to have a pretty good reason. Because when I called the gastroenterologist, he told me, why are you calling me? Are you calling me because someone told you to call me? Or do you have a specific question in your mind? And he was not rude. He was trying to understand why he's being called. So that is the same framework that I go through. Like, okay, fine. The surgeon wants a lung doctor. I will talk to the surgeon. Why do you want the lung doctor? So the surgeon will say, I want the lung doctor because the patient has a history of COPD. So say, okay, what is the question that the lung doctor will answer for you that you're concerned about? And that is vital, because if the CO2 is 65 and the pH is 7.4, the pulmonologist is not going to do anything dramatically different. But if the pH is 7.1 and the PCO2 is 85 and the intensivist is stuck, then you have a specific question for them to answer, which is, what is my next modality to help the intensivist move forward? So the intensivist needs to understand that they have come to the end of the road and they have a specific question to answer for the consultant. That is one cardinal rule that we should follow. And the second rule is, don't consult for the sake of getting more people to make your decision process easier. It will often do the opposite thing.
The opposite, exactly. That is precisely
terrible. So A, have a question in mind, and B, do not call just because you want to feel easier that you have more cooks. In the kitchen.
It's like when you are in trouble.
If I can just interrupt, sometimes nowadays it's for so-called medical legal reasons, because long ago, this is maybe 15-20 years ago, a patient who developed chronic osteomyelitis after some orthopedic surgery, eventually in the court, the anesthetist was also found, for want of a better word, guilty, that he didn't call a cardiologist when patient had tachycardia. So we have such stupid decisions being made in the medical legal realm. And that is one of the reasons why I think in corporate people want, I mean, an ordinary hysterectomy patient goes and sees 3 consultants and comes. I mean, it makes no medical sense. But so, the gynecologist seems to feel that if a cardiologist has seen the patient, they are somehow, protected. And I actually say the opposite, because if everyone sees the patient casually because they know nothing's wrong with the patient. So if actually something goes wrong, it will only go against you medical legally, because there will be so-called proof that there was nothing wrong with the patient. So one of the reasons for this too many referrals by surgeons or anyone else, the so-called primary consultants in the ICU, I think is for this so-called fear of litigation, that why you didn't call, because we get calls from children or siblings from the US saying, oh, if the blood sugar is high, why is the endocrinologist not there on the case, or why is the diabetologist not? I mean, the public perception is a little weird.
This is how I deal with it. So for the young surgeons, we try not to dictate our practice based on what the court is going to do. But many people will tell you that's the reality, like Dr. Vidya is saying. So here's how I typically go about it. Before you start working in a hospital, get a good lay of the land as to who are the good consultants who you can actually talk to. Try and understand the way they are thinking. And let's take this gynecology example, for instance. You need to know that you can talk to this cardiologist and tell them, listen, I'm being forced to consult you. I don't have a specific question. My intensivist, and we don't even care about the tachycardia. We just wanted to come address it and leave. Please don't feel bad if we don't, follow your request. We don't want unnecessary medications. This is the intent of the consult. Be open and frank with them so that they don't feel slighted. They should not feel like I, ordered metoprolol, heart cath, and atorvastatin, and you do anything. You need to have a group like that. You need to have open-minded consultants who you can talk to, who understand why you're consulting them. Again, the reason to consult is not always medical, right? But then at least tell your team of consultants that, hey, listen, this is our style of practice. We want to be defensive, which is not always a good thing. But you can say that we will still do what is right for the patient. Just say this is sinus tachycardia and requires no other intervention. End of story. Don't prescribe 5 other medicines. I'm not calling you to increase the length of my medication list. So you have to have a group like that. And when you have a group like that, it can be rewarding for decades to come. So you can have an endocrinologist, a cardiologist, have a like-minded thinking group like that. Otherwise, you'll have consultants that are going to really destroy your peace of mind.
Dr. Dileep, I have a question.
Give me a minute, Ilano.
Oh, sure.
Very sensitive. You're a very decent person asking decent questions, but I'll ask a not so decent question to Dr. Dileep and Dr. Bisuru. What is that you don't like in surgeons in the ICU, don't like them doing, which you never wanted to tell, or you wanted to tell, but you could not tell? This is the right forum. And what is that you expect them to do, which they are not doing? Dileep and
Communicate, talk, and be open-minded. That's
communicate
really,
with whom?
With every other doctor and the patient. Communication is a virtue.
Exactly on the same question, I'll put a scenario. Okay, I had a 88-year-old pancreatic issue. I did a Whipple. Patient had a very smooth post-operative course, recovered. He developed AFib. He's 88. LA, I think, was slightly large. He was at risk for AFib. So being an international patient under big direct eyes of the management, so he was shifted to the ICU. And our intensivists started on amiodarone. So I said, listen, guys, these guys have physicians from US. The policy is to start beta blockers or diltiazem. You have to have rate control, not rhythm control. But I'm not interfering. It's your baby. I just want the AFib control. They gave amiodarone for 5 days. On a Sunday morning, I was really pissed. I rarely get angry, but that day I said, I'm going to you can hang my patient upside down, but if you're going to keep him in the ICU for no reason, then I will take it up higher up. Then he said, Dr. Ilango, you are not a physician and this is not your patient. I will do what I like and you have no right to talk about atrial fibrillation. You're just a surgeon. I really, that irked me a lot. I took the issue to the management and said, listen, this is not how it is treated. Your intensivist may be a big person, but he's making a mistake. And I'm answering the US physician every day saying, no, there is a way these people treat, it gets controlled. The whole family understood this problem. Now, I am the one who is communicating. I'm communicating with the family and I'm communicating with the intensivist and I'm communicating with the management. Where do you think I went wrong? Is it because I was an intruder in the ICU? Because I had some knowledge of managing these AFibs in a different scenario, okay? So I knew what dose to give and how it is corrected. I did take the cardiology consult and the cardiologist note was simply written off. He said, no, I don't have to prescribe your prescription. So what do you do in this situation? So that's...
Ilango, can I ask you?
Yeah.
Why the relatives never spoke to your intensivist? Why you were communicating continuously?
So that's the issue. They live in an ivory tower, okay? So they come, like how Pattanathakrishnan sir was saying, some junior will be there. I will go and tell them, guys, what are you doing about AFib? You know, rate is still there. Sir, it is not converting. We are still giving amiodarone. It is not working. It will get controlled, sir. We have got good experience. So I will finish my rounds. I have got my work. I have not got my surgical stuff to do. I go down, I come back in the evening. Again, another junior is there and he will say the same thing. And I caught hold of the senior and said, you are answering this question for me. He said, if you want to treat AFib, you treat on your own. Don't involve the ICU. You can keep in the ward. So it went back and forth, but I am sometimes very adamant. I did solve the problem.
Just a question. Do you have an ethics committee in the hospital?
Not in this place, no.
So that's fine. So this is conflict resolution 101. Here you're not at fault, at least from a scientific standpoint. Clearly you're not at fault because even in our own internal protocols, we do not use amiodarone as the go-to drug. It is beta blockers. There's no question about it in the ICU. Now, there is initial literature that in the anesthesia realm you kind of use amiodarone, but that's fallen out of favor because most post-op AFibs are due to adrenergic tone and you need to use a beta blocker. That's pretty much the norm these days. Now, my question is actually related to the question that Dr. Biswarup asked, is that why were you heading the discussion with the family and not putting the feet of the intensivists on the fire to say, hey, can we do a patient family discussion ASAP? I'm going to give it 20, 30 minutes of my time. They have some probing questions for you. Let him handle it. If he is cocksure of his intent, let him get the heat from the physician family. Because I'm assuming this is sort of like for the want of a better word, a closed ICU model. If the intensivist wants to make the decision, hold his feet to the fire and let him defend his decision because he is the doctor of record.
See, that is exactly what Patta Radhakrishnan sir was saying. So the seniors will round at 10 a.m. By the time surgeons will be in the theater. So morning you go at 8 o'clock, one junior is there. Evening 4 o'clock you come back, another junior is there.
So
you
your ICUs, you need a process. You need a defined family counseling time where any relevant consultant is actually available. This is the problem of communication.
All right, I'll come to the next question. Patta Radhakrishnan sir, I think Vidya ma'am, I have some time, or am I interrupting?
No problem. As long as Dileep is willing to listen, we are all
as
fine.
long as he lost his patience, yes.
So we'll go back to the acute pancreatitis regimen. No, there is a standard conversation which every intensivist has. All the family goes. This is the story. Your patient is very sick. It goes like this. Okay, one, your patient is very sick. He needs to be in the ICU. There is a high risk of ventilator use. There is a high risk of dialysis use. There's possibility of antibiotics. There's a possibility infection will not get controlled. There is a possibility of death. Every day they will say this. How I learned this is I didn't know any of this counseling stories because I counsel all the patients myself. And one of the patients, they used to come and meet me at 11:30 or 12, and they said, I don't care what the intensivists say because they are pretty much saying the same thing every day. So they lost faith in what they were saying. So how do you handle this? You allow them to go to a counseling session and you find them saying the same thing, See, my wife is an intensivist, and Dr. BKM is here. BKM is one of my mentors. So BKM taught a lot of intensive medicine for me, intensive care medicine. So what you should aim is, what is going to happen to the patient in the next 24 hours? What's going to happen at the end of the week? How am I going to get him home safe? So that was the goal. Every day I keep thinking, but today I go to the ward. The same experience is there with my wife too. She has a liver failure patient and everybody manages for the day. That is something which really irritates a person who focuses on a critical specialty like transplant. You go there, no progress is bad progress in intensive care medicine. I find the current crop of ICU physicians, even though they have degrees, they fail in these circumstances. But I've not seen the same situation in US. I've faced the same set of physicians there. They had lack of knowledge about surgery, but their ward management, the ICU management was great. But here in India, we find that gap very often. They manage through the day and they say, oh, my job is done. See, recently I lost a 13-year-old kid, child with acute liver failure. Liver failure, worked up for transplantation, developed fever. It was a spontaneous bacterial empyema, required antibiotics, but the child was very restless. So I kept him in the ICU. Nighttime, an unconnected person came and said, this patient is very irritable, and sedated him. 2 a.m., we lost a child because he arrested and nobody noticed. I still live with that guilt. And I could not bring him to justice because he said, this patient was restless. He arrested because of some reason. He brought out so many reasons. But I feel that the sedation was the tipping point. So the question is very, very important. A surgeon is a partner, and I believe the ICU physician is a partner in the better care of the patient. And good informed physicians and surgeons will work together for the betterment of the patient on any day. But I do find I have to take more burden on the ICU care because they are not taking the same effort as I as a surgeon, I have taken to understand intensive medicine. They have not taken the effort to understand surgery. That's my grudge. Biju is laughing. Yes. Are you going to add up something?
With Dr. Bishuru telling, intensivist knows a little bit about everything, but scientifically speaking,
not little bit, something of everything. Little bit and something else.
If you take the pathophysiology of most of the critical patient, actually, if you zero down in a pyramidal model, but that something is about everything is actually going to be a most of the thing about something. Actually, it's an inflammatory pathways. All these things are finally zeroed in, and it reflects in all diseases. So scientifically speaking, if I convert your sentence back to her, they know a good chunk of the things which happens in all diseases. So that
Absolutely.
the
Absolutely.
commonality I feel. Yeah.
I think Ilango just happened to go through a patch of bad experience. It is not as bad, Ilango.
It's just, sir, I have got very good ICU physicians who are good friends. Looking at them, I feel there is a gap among the youngsters.
What happened, although we are on a forum, over last 10 years, there has been a tendency to create as many degree holding intensivists in this country. And recognition for training of this IDCCM, I know Raymond is there on the forum. I hope he's hearing. I think the training and the exam both are totally diluted. And as a result, because this is a subject where you need more of field along with knowledge, just mugging up something does not create a clinician. So you are right in your observation, and this is the etiopathogenesis behind that observation. That last 10 years, definitely training and the quality. Far too many hospitals are accredited for ICU training. So people are entering as qualified intensivists even before they have acquired or attained that requisite level.
So
I agree with you.
just a quick point here. Let's get some hard facts. There are 4,624 qualified intensivists in India today, as per my last count, which is a astonishingly small number for roughly 2.5 lakh ICU beds that exist. So you're not going to get quality at scale. Let's be at peace with that fact. The second problem is that the ICU, bulk of your care for the patient involves strong communication skills. You have to have strong communication skills. And MBBS curriculum is woefully short of that. Skill, strategy, and training is not taught from a communication perspective, and it gets worse in MD and DM because the trainees get a feeling that with enhancing knowledge they need to use fewer words to talk to the family, which is a huge fallacy. So if Dr. Ilango is counseling the patient's family and doing his counseling himself, the intensivist should be there lock and step, doing the same job with the same degree of efficiency and 360-degree coverage.
Not by compulsion. Not by
compulsion. That is the job requirement.
That is the requirement. That is what.
Yes.
Correct.
So the IDCCM degree is just a label, right? It's just a placeholder. It's a placeholder that has to mean something. And what that's supposed to mean is that whether you did anesthesia and reach critical care or medicine and reach critical care and pulmonology reach critical care, you need to have a common foundation of what critical care means. And it does not simply mean getting a DNR consent or saying that you're going to die today, you have 25% chance of death, you have 33% chance of death. This is meaningless numbers. Anyway, only 10% of what is told actually gets digested by the patient. So one of the problems in modern critical care training in India is that in some places it is very structured, but in almost every place, fundamental communication of complex physiology is not taught.
Absolutely
Right.
And that is a problem. As long as intensivists and surgeons don't understand that, we are going to keep going on this train where, oh, this happened, the patient was, maybe there was something else that intensivist could have done for the restless patient. Again, I say communication. I don't say communication between intensivists and surgeons. I mean communication between intensivists and intensivists as well. What did the day intensivist tell the night intensivist? What is the handoff procedure? What is the handing taking over from shift to shift? These are huge things that need to be,
Dileep, I'll interrupt just once. Actually, 5 years ago, I did an audit over 8 weeks of handover and takeover, handover and takeover. It used to happen 3 times a day. And I created an audit data as to inheritance of mistakes and adding new overlooks, and it carried on. Finally, when a patient with an ALOS of about 4.55 days, each patient on their last day were standing on many overlooks, many mistakes. So Dileep, what Dileep is saying, I want to reinforce. It is not just about technical training like lines, becoming a good linesman, putting lines, or writing to broad spectrum antibiotics as a robotic response. There's a lot of mental training involved, That is very lacking over last 10 years. I am absolutely sure of it. In pursuit of numbers.
So Dileep, we didn't want to disappoint you. Okay, so this is
Dilip,
exactly what we had in mind. we wanted, see, this is a very passionate thing for us, because like how Biju was telling, transplant is half medicine and half surgery. We have to match the physiology of the recipient to the graft, and quite a bit goes in. There's a lot of ICU care involved. So I was forced to learn.
No, in fact, Ilanko, I share with you, if I had that situation, a 13-year-old given sedation at 2 o'clock by a person who had no connect with the past present of that patient, probably I would have thrown him out for 1 month. I have done that. I have earned bad name for it, but not that it took me out of my guilt feeling, but it is a truth. So you are a milder person than me, actually. I don't know how Dileep is, but Dileep is lucky he's not in direct contact.
Dr. Dileep, can we see that any important questions in the chat box also? Many people.
I addressed most of them. I've replied to them via text.
You can summarize how to build bridges between surgeons and intensivists, in a couple of words.
There's one among all this hot discussion. There's one very simple question: is there any role at all for dextrose in a post-operative patient who's starving? Very fundamental question. I think Meenakshi raised it. It's somewhere lost in the chat box.
See, if you're going to start dextrose, how much will you give it at? You'll give it at 100 ml per hour or 75 ml per hour, something like that, right? Because if you give a higher dose, you're going to cause hyponatremia, you're going to cause an excess free water load. At doses of 75 to 100, hardly anything goes. It's 5 grams over 10 hours. It's nothing, right? So if you want to meet nutritional needs, you have to do it the right way, which is use the gut if you can. Usually in the first 7 days or so, trophic feeding is okay, meaning even if you are not able to meet total caloric goals, you don't need to go overboard with starting TPN and all that if the patient was previously normocaloric or eucaloric. If they're a cancer patient and have not been eating for 3 weeks, then yes, you have a good reason to start TPN. But oftentimes I see TPN being started too early without giving enough time for gut-based nutrition, because again, catabolic patients, TPN is not going to stay in the system. It's going to just be converted to urea, and in 2 days, you'll see the BUN rise up. So dextrose is not your solution. You want to do nutrition, you have to do it right. And, decide if the gut is the way to go. If the gut is not the way to go, count how many days you have before you can start TPN and whether TPN is the right choice. Use your dietitian's input to understand the caloric needs and take a call. Metabolic carts, calorimetry sort of fallen by the wayside because they're good scientific exercises, but have not been shown to improve outcomes at all. So I'm very pragmatic there. And
so
I think
short answer is if your patient is going to be fasting only for 24 to 48 hours, you don't need anything. Nothing, unless the patient was very badly in a very bad nutritional status before. In fact, you would have started something before.
In fact,
I have a different opinion regarding this, because I think most of the trials are focusing on post-op nutrition, but I think we have to really count in US and Western hospitals, they admit on the same day and the process starts there. But in Indian hospital, before I think making a decision of immediate post-op nutrition, we have to think what is the pre-op status of that patient.
Yeah, that's what I mentioned. So
yes, it should be a continuum. That's what my opinion.
No, it's always a continuum, doctor. It's always a continuum. If there are definite guidelines, if the pre-op nutritional status and the score is poor, there's no question you need to start some nutritional support, whether enteral or TPN, immediately post-op. There's good guidelines for that. The only point here is that dextrose is not going to be your solution. You have to have a formal strategy that looks at the entire package of proteins, carbohydrates, and fat. Just 24 hours of dextrose is not going to do anything.
Yeah, the way I'm telling that, just commenting, because we have enough number of patients where even the post-op day 1 evening, he will be on TPN. So because it may be a continuum of something happened in the pre-op. So.
Yeah, if there's a rational reason for that, that's totally fine. So for example, if their BMI pre-op was 15 and they have severe hypophosphatemia and other problems, clearly you need to do something. You're not going to wait for the gut to start working. So if your intensivist quotes the NEJM study and says the ENIAC trial shows you can wait for 7 days, that's not the patient that was studied.
Exactly.
Yeah.
So, yeah.
So pragmatism is encouraged on both sides.
And also, I think Dileep mentioned Dileep is very pro ringer lactate, which is what I would think so. The lactate metabolism also 2/3 is bicarb, 1/3 is glucose. So that gives enough background of normal euglycemia. Patients don't become hypoglycemic on ringer lactate. And once dextrose is metabolized, it's just pure water. So it's so hypotonic. It just percolates out.
If any of the attendees would like to ask any question, feel free to unmute yourself. Otherwise, we will ask Dr. Dileep to round up the session. If anyone wants to...
yeah. Madam, yes, I would like to comment a few things. That in today's, today only, I have come across a patient who was suffering from a large breast lump, 45-year lady. After evaluation, on mammographically, it was Birad's category 4 lesion. Subsequently, patient was having grade 2 dyspnea, and I have referred the patient to cardiologist. Now, after going to cardiology, the cardiologist has advised that there is a sinus tachycardia. Her recently diagnosed diabetic level was 237 random, and patient cardiologist has given that you may require angiography, and subsequently we have to rule out other probable causes. Sinus tachycardia is there, and ECG was normal, 2D echo was normal. Now patient came back to me and said, which is more important, either the breast lump removal or true cut biopsy, or I will first go for the angiography. Now in this scenario, if the breast lesion turns out to be malignant, we cannot operate if the patient had been undergoing angiography followed by angioplasty for few days. Now here what we should counsel to the relative, even though we do not go for angiography evaluation, and if patient had a problem on the operation table, that is also a problem for anesthetist as well as the surgeon, if accidentally it happens without undergoing an angiography. So what is your advice as a physician in such scenario, and what should be the role of surgeon, as many of the senior colleagues are here?
So was your patient anemic? That's probably in a 40-year-old with advanced malignancy. That's probably more chance of the reason for dyspnea than anything else. So other than the cardiologist, I think, and now that's the other problem. Just like you said, just like I mentioned about people asking for cross referrals for so-called medical legal reasons. Another thing that we find about cardiologists, some of them even write it on the back of the page. The main reference will be in front, and on the back they will write small letters, angio may be done or something like that.
The last line was she may require an angiographic evaluation. Last line on the, as you have said, the back of the page. So so in such scenario, so after the relatives came to me, I have counseled them well that yes, if he has advice, it is up to you. We cannot take the risk as a surgeon. First you go for the angiographic evaluation. If it turns out to be normal, we can go ahead with the surgery. So such is the mentality of the surgeon. But if the patient admits in the ICU, they will first try to sort out what is the problem with the surgeon. Is there any problem with the previous surgery which patient has underwent? Is there a problem of local sepsis? Is there a problem with surgery? So these are some of the factors and the change in the thinking pattern that I want to say, being a physician and being a surgeon.
Anyone else wants to comment on that? Pata, what would you have done in that situation?
No, I do respect my physician's opinion, and as rightly pointed out by Dileep, that which physician is saying what. You are sent to the right physician. I'm worried if somebody says angio. I really look at it very seriously. And I know my physician will not say it is not required. I think we should have a network of that nature and then decide. Same with, in spite of whatever I said a while ago, I do believe in what my ICU consultant says. We saved so many patients whom I thought will never survive. Actually, I feel comfortable. Actually, once the patient is shifted to the ICU, I'll forget about the patient. I'll just sleep happily, however bad the patient is. Because, you know, the ICU consultant take it up so seriously, and then, you know, they'll try to bring the patient out. Most of the times.
So in the end of the day, I think it's all about communication. Communication.
Ilago, you raised your hand.
Yeah. Vidya ma'am, if I can continue.
Yes, please.
So Dr. Anjali's question is quite common here. When you do major surgeries, it's a mandatory requirement in a hospital to get cardiology and pulmonology clearance. So for one of my whipples, he had a change in the stress thallium. He was a slightly elderly person with diabetes. So he underwent the regular routine evaluation. Stress thallium showed some changes. So he was asked to undergo angiogram. And when they came for counseling, I said, listen, your cancer is a dangerous cancer. Yes, we agree with that. But if you have a heart attack, you're likely to die immediately. The impact of the cancer will never be felt at that time. So my suggestion is, let's fix the heart. And once it is done, we'll take up for surgery. We took for angiogram, found triple vessel disease and required cabbage. So it was taken for surgery. We had no option. They did the surgery. I waited for a month and a half or two, and under heparin cover, we did a Whipple. The cardiothoracic surgeon and the cardiologist were supportive during the postoperative phase, and the patient did well. So this problem is not going to go away. Indians have very poor metabolic profile, you can call that. And you are likely to see more and more of these patients with cancer plus this, that. It's very common to see NASH cirrhosis nowadays in 60-year-olds. So you'll see it very often. So I think surgeons must learn the art of knowing the boundaries, at least the basic boundaries of every disease. So I still buy the basic Davidson, the basic Harrison, and just browse through it. It's not that I understand everything, but you have to browse through it to at least understand, to see where the physicians and the cardiologists or endocrinologists are drawing the boundaries. So that is how I feel. This problem is going to become common in the future, and it is better for the surgeon to know these things, because a problem in the heart will kill the patient, and ultimately the surgeon will be blamed for everything.
All right. Okay.
So Dileep, if you'd like to just summarize, and we've been here for more than
an hour and a half,
45 minutes. So.
No, thank you for having me here. I'm obviously humbled. It's nice of you to consider me to speak with you guys, and it's been a very engaging and engrossing session. I mean, the idea here is that neither surgeons nor intensivists are villains. The villain is obviously the cardiologist, right? As we have so I think since we can all agree with that, I just want to say that it's going to be a more and more complex landscape. That is only going to be communication that is going to save us from all these challenges. Knowledge is going to play a role. So for example, in this cardiology case, we can talk about the fact that, you know, a stress test is not going to change outcomes, has never been shown to do that. Maybe the triple vessel surgery was not required because many patients have stable triple vessel disease, and the treatment of choice for triple vessel disease when you don't have symptoms is optimal medical therapy. So, you know, there are so many minefields here that it's going to be hard for us to navigate, and no one's going to have the right answer. So the ideal thing is to make sure you find the right group of people to work with, because at the end of the day, it's good human relationships and good solid communication with an open heart that's going to allow you to sleep well at night and make sure that you are actually a sane person to talk to the next day. So my take is that you can have whatever specialty you want. It's your mindset that is going to change the game at the end of the day. So with those words, I thank you all once again, especially Dr. Vidya, for having me.
So thanks, Dileep, and thanks everyone for interacting so well and getting the best out of Dileep. And we also thrashed out a lot of problems that we all face. Next week we'll be talking about burnout, which is a very common thing, especially among intensivists, anesthetists, and surgeons, especially transplant surgeons. So please do log in next week at 8 p.m. for the next episode of Marvelous Medicine. Thank you everyone once again, and hope you're all vaccinated. Stay safe. Good night.